And so as mentioned, there's two forms of impaired kidney function, CKD and AKI, and I'm going to talk about each of these in turn now. Okay, turning now to pharmacokinetics and chronic kidney disease. This is the overview of the topics that we'll be discussing during this presentation. It's very necessary for us to be alert for impaired kidney function and to be able to diagnose it. This is important for a few reasons. One is it can influence treatment decisions, but number two is that chronic kidney disease is generally an asymptomatic disease until the very end. So if we're not doing blood tests to measure kidney function, we may not know that someone has impaired kidney function, and therefore we don't know to dose adjust. How do we diagnose chronic kidney disease? This is how we stage chronic kidney disease. We have stages of 1 through to 5, whereby 5 is the worst and 1 is the best. Two factors are considered when we're staging chronic kidney disease. One is the presence of kidney damage. This relates to whether or not we see proteinuria or hematuria on testing in the urine. And the other relates to renal function, which is based on here, the eGFR, which is mils per minute per 1.73 meters squared. So we can see here that as renal function drops, the stage increases. What is the impact of chronic kidney disease on pharmacokinetics? So the first principle we'll be talking about is absorption. When we're thinking about absorption, we're thinking about how does absorption in patients with chronic kidney disease vary compared to the healthy individual without kidney disease. And the second relates to how it compares within patients with the range of chronic kidney disease, whether it be stage 5 or stage 1. And we know the drug absorption can be highly variable in all of these cases. There's a lack of consistency between data that's identified in different studies. It's commonly thought, though, that absorption will decrease in patients, predominantly when there is edematous states. So if you have edema, peripheral edema, then you may also have marked edema within the gut wall, and this may impact on drug absorption. But the data has actually been quite conflicting on that, and certainly it's not always reliable. There's been even some cases whereby, and this is in animal and human data, whereby drug absorption may actually increase. And one of the theories for this may be is that edematous states or some other damage to the gut wall may impair the active transporters and enzymes that are present there, which contribute to the lower bioavailability of some drugs. So in this case, uremia or fluid absorption may impact on usual protective mechanisms. What about volume of distribution? Well, volume of distribution varies not only with body mass, but also with body composition. This relates to water or adipose tissue. So changes in volume distribution probably depends on the drug that you're thinking about. We know that in advanced chronic kidney disease, there is risk of fluid retention, hypoalbuminemia, and both these factors can also be contributed to by decreased protein binding, which may relate to accumulation of uremic toxins. The presence of severe edema on the impact of volume distribution is fairly inconsistent, and this may relate to the fact that we're looking at different drugs with different physicochemical and pharmacokinetic properties, so there is no clear rule. But probably what does happen is patients which are more hydrophilic in nature are more likely to have an increase in their volume of distribution because there is some water retention. However, even in dialysis patients, the interdialytic weight gain that occurs is relatively small compared to the overall body volume, and therefore this tends to have a relatively small component. Some patients can have sarcopenia, which means general muscle wasting, and this is a particular problem with patients with advanced chronic kidney disease. And in that case, there may even be a decrease in the volume of distribution. So it can be concluded that volume of distribution can change. It can go up and it can go down, and that depends on the drug. And I'm sorry that I can't give you any more reliable predictions around that. Clearance in chronic kidney disease. Well, I've said this a couple of times, and I'll say it a few more times. This is the main pharmacokinetic change that occurs in patients with impaired kidney function. We know that multiple conditions can cause chronic kidney disease, and we're starting to learn a bit more about how the different conditions may actually impact on the changes in clearance. In chronic kidney disease, we generally consider that the decrease in GFR relates to what's called nephron dropout. So it's not that a certain number of nephrons are functioning to a lower level. It's actually that a certain number of nephrons have died. So there is sparing of nephron function, and that these things are all proportional. So this is what's been called the intact nephron theory. So I've told you before about how you can get metabolism and active secretion at the kidney. It's always been put forward that all of those functions are in proportion to GFR because we have an intact nephron. And we're going to talk more about that and some of the limitations around that, because it's more complex than that in reality. I showed you this slide before, which is a very important one. And in particular, if I can draw your attention to this point here about how total clearance relates to the sum of clearance from other processes or organs, including that of the kidney. And we'll come back to that again. So how do we quantify GFR? I've already told you that GFR is the most important measure of kidney function. That's how we grade kidney function. And if we think that through the intact nephron hypothesis that all functions of the kidney are proportional to GFR, then surely it's very important for us to understand and quantify the GFR if we're going to be using this to dose our medicines. There are multiple methods by which we can quantify GFR. The vast majority of these are all based on serum creatinine concentrations. And there's three ways that we can do that. One is to measure creatinine clearance, and this is done through a 24-hour urine collection. We'll talk more about each of these as we go through. The next is what I call, and many others call, the estimated creatinine clearance, which is actually the creatinine clearance based on the Cockcroft-Gault formula, which is known and loved to many of us. And again, we'll talk more about that. And the most common method of measuring or quantifying GFR is the eGFR, CKD-EPI, as shown here. We can also do a measured GFR. This is a gold standard. This is where we would inject something into a person and then we measure its clearance through the kidneys. And there's also a new guy or girl on the block called cystatin C. This is a relatively newer test which is now available to help quantify GFR. I'm not sure if this is currently available where you are. From my perspective here in Australia, it is available, but it's largely based on limited circumstances. I would need to contact my laboratory specifically to order it. It's not part of a routine panel. Let's talk about each of these. So when we're thinking about serum creatinine-based formulae, we know here that the premise of this is that creatinine excretion is proportional to kidney function. So if kidney function halves, then we're going to have a doubling of creatinine. The problem with this, though, is that creatinine production is proportional to muscle mass. So there are some individuals whereby this would not be helpful. For example, if you've had an amputation or you're in a wheelchair, so you have what's called disuse atrophy of the muscles, particularly in the legs, then because you've got a lower muscle mass, you're going to have a lower production of creatinine. And so many of these formulas will be wrong. On the other side, for people who have a higher amount of muscle mass, and this may relate to obesity because more muscle is required for mobilizing, but particularly for people who build muscles, with their higher muscle mass, it means that they've got a higher creatinine concentration. And this doesn't necessarily mean that they have impaired kidney function if we look at a blood test. So there are a number of people whereby these formulae aren't certain. We're going to talk more about those in a moment. Let's start first with the 24-hour collection. This was always the gold standard prior to the publication by Cockcroft and Gault in 1974 and a few others around that same time. This is where as mentioned, you need to collect 24 hours worth of urine. And this is difficult because all of us pass urine at different times. It's very hard to say that any particular time of the day we would most consistently pass urine, and therefore that's when we would start a 24-hour collection. The most consistent time when someone would pass urine is in the morning when they wake up after sleeping. And so if you are doing a 24-hour urine collection, unless the patient is catheterized, then it's best to start the next day in the morning. So when they wake up in the morning, they empty their bladder into the toilet, and then they start collection of the 24-hour urine collection. And that can continues until the next day. The problem with this process is that it is error prone. Quite often samples are missed, even with very careful supervision. Also, there's a time delay until you get the results. It takes at least 24 hours for the samples to be collected. And then after that, the sample needs to be processed by the laboratory, calculations performed. And it's inconvenient. You're largely telling patients that they need to stay in hospital, stay at home, so that you can measure this, so that because they don't want to have to walk around the streets carrying a large urine collection bottle. Creatinine clearance by this method also slightly overstates GFR because there is some active secretion of creatinine in the proximal tubule. So the next one is Cockcroft-Gault formula, or E-creatinine clearance. It's called the E-creatinine clearance because the gold standard upon which Cockcroft-Gault was based was a 24-hour creatinine clearance. So it's really just estimating the creatinine clearance of that. So that's important because, like I said before, this will slightly overstate GFR because of the active secretion of creatinine into the proximal tubule. This is recommended for many drugs, and it's something that a lot of us have been taught as part of our education. But a problem with this is that, firstly, it requires us to do a calculation. And when you've got humans doing calculations, there's always a risk of error. The other issue is that since 2010, there's been a change in the way the assay has been performed. And this was in an attempt to standardize the assay across the world. And in doing so, it's now reduced the accuracy of the predictions by Cockcroft-Gault, because we're now talking about a slightly different assay. It's probably only changed estimates by about 10 to 20%, but it is still a change. And the next question is, this is the formula up here, what body weight do we use? Do we use actual body weight? Do we use lean body weight, ideal body weight? This can be very important because some people are quite slim, some people have more weight to them, and that may not all be muscle weight or water weight. And so therefore, we need to consider which body weight to use. And I'll go through that in a moment. But it's important to remember that all of these things are only estimates. So this is a publication from 2009 which compared the Cockcroft-Gault eGFR to inulin GFR, which is an example of the measured GFR that I told you about before. And while we can see there's very clearly a proportionality there, a correlation, what we can see is a lot of scatter of the dot points. So it's not very accurate. So if we had someone with a measured GFR of 90, we may get a Cockcroft-Gault GFR, which is very easily between 60 and 120. So there's a lot of error within these estimates based on Cockcroft-Gault. It is not a pure measure of kidney function. The next one is eGFR or CKD-EPI. As you know, we love this for so many reasons. It's automated. Whenever we order a creatinine, we automatically get back an eGFR. Therefore, it's readily available, and it's commonly used for all of these reasons because it's very practical. But the issue with this is it's not formally recommended for many drugs. Most drugs were developed in the day when Cockcroft-Gault was used, and therefore that is a recommendation of what we use. And also, it doesn't incorporate body weight or height at all. This is produced by the laboratory. They have no idea about the body status or morphology of our patient. We need to know that. And so then we need to consider if we should adjust this GFR for some people who have extremes of body size. As you can see here, eGFR is indexed to a body surface area of 1.73 meters squared, of which not many people in the population are that size. They're actually larger. And we'll talk about how we respond to that in a moment. Similarly, as shown with E-creatinine clearance, eGFR also is a very poor estimate of measured GFR. So this is showing estimated GFR on the x-axis, and on the y-axis is the measured GFR. In both cases, they've adjusted for body surface area. So it takes away the factor of the patient's size or morphology. And we can see here that ideally it would be a flat line of 0, but instead we're getting lots of spread of data. So again, someone with a measured GFR of, say, 60, then the estimated GFR could be anywhere between minus 30 or plus 30 from that. So there is a lot of error within that as well. I mentioned to you about how a problem with EGFR is we don't know the weight or height of, is that the laboratory doesn't know the weight or the height. This is where it's then our job as clinical people to be able to adjust for that if needed. So if we look at the original CKD EPI publication, it was done mostly in patients who are all less than 66 years of age, and their body surface area was 1.9 to 1.93 meters squared with a BMI of 27 to 28 kilos per meter squared. I'm sorry, I just realized that I only have them in metric units. Apologies. And also weight and height of 170 centimeters and a weight of 82 kilos. So 80 kilos would be about 170 pounds. And so I don't have that many patients who fulfill these criteria. Most are a bit taller than that, and certainly many are higher weight. If I look at these numbers, these don't apply to me. I'm much heavier and I'm much taller than this. And so therefore an EGFR may not be fully reflective of my kidney function, but also that of our patients as well. And so it's possible to adjust for the EGFR for our patient using this de-indexing formula, which is simply where the patient's GFR is their EGFR times by their body surface area divided by 1.73. This is something that I not uncommonly do, this calculation, to work out a better estimate of their GFR when I'm considering dose adjustments. This is a summary table which talks about how different patient characteristics may impact on the E-creatinine clearance or the EGFR from a paper that we wrote a year or two in a journal called the Australian Prescriber. And it shows how in patients with reduced GFR or higher body surface area, older age, younger age, obesity, or perhaps particularly more lean, it talks about which of these two formula may be more accurate or less accurate. This is largely based on limited data, but it gives an indication. But in general, as I've already shown you, both eGFR and E-creatinine clearance have so much error compared to the measured GFR. In general, I think it doesn't matter. But what I think is more important is that if someone has a particularly high BMI, for example, a weight greater than 120 kilos, which is about 250 pounds approximately, or a BMI which is less than 60 kilos, which is about 130 pounds or 18.5 kilos per meter squared, then we need to consider other alternatives. And that's where for GFR, we do a de-indexing of the GFR. And for E-creatinine clearance, we use the adjusted ideal body weight. Or if they're lean, then we use their actual body weight. And again, we de-index the eGFR. So there are different ways that we can do this depending on what you prefer. But this is the rationale for why we would change these measurements, how we would deal with these changes in patient characteristics, and why, in general, I think it doesn't matter which one you choose because they're all a bit wrong. Remember this slide where I spoke about how you have 3 different types of drugs, and we spoke about a few different examples and how they change with GFR. Sorry, about how a change in GFR changes a drug clearance. Let's talk more about this in the context of chronic kidney disease, because this looks like a very stylized and ideal representation. I've changed that picture slightly so that I've normalized them all to a single point here of 100%. But you can, and I'm sorry that the color is different, but we can still see here that this is the one which is proportional to GFR. This is the one which has a mixture of kidney and non-kidney clearance. This is an example of a drug that has complete kidney clearance. Let's look at some real data to see how this reflects real life. This is showing the influence of creatinine clearance on meropenem clearance. So meropenem, as you know, is an antibiotic that's completely renally eliminated. And we can see here that these data points, although there's a bit of variability or spread, we can see that in general creatinine clearance is completely proportional to meropenem clearance. So that's consistent with the line that we showed here, which is the grey one. And that's what we'd expect. Then if we look here at changes in creatinine clearance with ciprofloxacin, again, this is an example of a drug where I said it's a mixture of hepatic and renal clearance. So about 30% hepatic and about 60% renal. And we can see here again, although there's a bit of spread and variability of the samples, again, it looks like this is performing as we would expect. Now let's look at roxithromycin. Roxithromycin is a macrolide that we use very commonly here in Australia. I'm not sure it's as common in the US, but it's a well-tolerated antibiotic which has few drug interactions. Only about 10% is excreted in the urine. Therefore, it's a drug that's largely hepatically cleared. So we would expect a straight line. Now we can see some variability here, but I think it really does look like there is a decrease in kidney function. That is, the kidney function decreases and there is a decrease in drug clearance. So this is unexpected. Why is that? Maybe this only applies to roxithromycin though. Maybe it's an aberrancy. Actually, it's not. And if I show you this figure, I'm sorry, it's the same figure that I've just shown you, but turned around mirror image, whereby this is decreasing kidney function, and this is changes in metabolic clearance. And we can see here that for a lot of different drugs, this is data based on a combination of animals and humans, whereby through pharmacometric processes and allometric scaling, they've been able to come up with a line that summarizes how these drugs clearance changes with impaired kidney function. We can see here that for a whole range of drugs, there is a decrease in kidney function. So there is a decrease in non-renal clearance with decrease in kidney function. Now, each of these drugs has been chosen because it's a probe for different drugs. So theophylline, for example, is a probe for cytochrome P450 1A2. Rosiglitazone is a probe for 2C8. Bosentan is for 2C9. Omeprazole is for 2C19. Bifurolol is for 2D6 and midazolam for 3A4. So this is showing that for a number of different sorts of cytochrome P450s, this effect can occur. For some, for example, omeprazole shown here, which is 2C19, we can see that metabolic clearance has decreased to 25% of, or lower than 25% of what it would have been otherwise. Whereas some of these other drugs, we can see that they still have more than 50% of their metabolizing capacity. So there's a lot of variability. And this is just based on those particular drugs. And it doesn't necessarily mean that all drugs metabolized by those cytochrome P450s will change to the same extent. So this is surprising. It's not predicted. Why is this? Well, if we go back to this figure that I showed you here, it probably relates to this. Circulating uremic toxins that inhibit these enzymes and impact then on drug clearance. So this then raises a question. Perhaps with higher amounts of uremic toxins, we have more severe inhibition or more marked inhibition of the liver enzymes. That's kind of what we're seeing here. As the kidney function gets worse, metabolic clearance gets worse. Well, that's enzymes. What about other drugs or other processes? This is looking at the disposition of fexofenadine, the antihistamine, in patients who are either without any kidney function or with end-stage renal disease or end-stage kidney disease. And we can see here that there are changes also with fexofenadine. What are the pharmacokinetics of fexofenadine? Well, it's not metabolized, but it's a substrate of transporters, P-glycoprotein and OAT-P1B1. These are both active transporters. Their role is to reduce absorption of drugs, so they sit on the gut wall and they extrude the drug before it gets absorbed. They're also involved with the excretion of the drug in the kidneys and also in the biliary system. And what we see here is that patients with end-stage kidney disease have a high concentration that persists for longer. If you prefer seeing a table with numbers, this is what we see. Noting that normally in health, bioavailability is about 33% of this drug. So therefore, factors that impact on bioavailability would increase the concentration. And this is what we see. So the Cmax is increased 1.7-fold. The half-life is 1.5 times longer. We have a halving of the clearance, and the AUC is increased by 2.8-fold. So this means to me that we most likely have an increase in absorption. So that may mean that those transporters are not working very well, and a prolonged elimination half-life, which is due to a decrease in clearance. And this must relate to due to inhibition of these transporters. further proving the fact that, or supporting the fact that end-stage kidney patients have used uremic toxins which are causing changes in function. This is where the researchers, again by Tom Nolan and colleagues, they obtained a blood sample from patients with end-stage kidney disease, and they incubated it with rat hepatocytes and enterocytes and looked at changes in protein expression for P-glycoprotein, OATP1A4, and cytochrome P450-3A2. And we can see here that there can be an increase in PGP or a decrease in PGP. There can be a decrease in CYP3A2. There can also be a decrease in OATP1A4. So this shows that uremic toxins are having an impact on protein expression as well, and that can be contributing to some of the changes that we're seeing. And the mechanisms of this, as I mentioned before, we're thinking about this is the lumen of the intestine, and that's the enterocyte. So drugs can enter the enterocyte either through diffusion or active uptake via a transporter. Once in the enterocyte, it can be metabolized, or it can be extruded by the PGP, or it can then enter the circulation. So this is part of our process of these processes contribute to bioavailability. Here in the portal circulation, they can be uptaken by the hepatocyte through either a transporter, and then within the hepatocyte, there can be metabolism where they can then be effluxed, or they can be excreted into the biliary system. So we can see here that there's multiple transporters and enzymes which may all be impacted on by uremic toxins. And it's these multiple impacts that can change the pharmacokinetics in patients with kidney disease. But ultimately what we would see is if there is less of the PGP, then we'll have a high concentration in the enterocyte. If there's less cytochrome P450 activity, again, we have a higher concentration. So we get a relatively increased dose due to the decrease in bioavailability, and we get impaired clearance as well. What may also be fascinating, we don't have a lot of information on this, is that the etiology or the cause of the kidney disease may also have an important impact on kinetics. For example, studies were done that showed that if you've got chronic kidney disease due to a tubular dysfunction, then you may have less clearance of drugs such as ampicillin and cefalexin than you would for patients with the same GFR who have glomerulonephritis. So what this means is looking at two patients who apparently have the same GFR, depending on the cause of their kidney disease, you may get differences in clearance. And this relates to the active transporters. So as we know, this is the nephron, where we get active drug secretion in the proximal tubule and active drug reabsorption in the distal tubule. If we compare these three drugs, benzylpenicillin, 50 to 70% of clearance is based on OAT, the organic anion transporting polypeptide, which is found in the proximal tubule. And so if you've got a tubular dysfunction, then you may, this may impact on the secretion. Same applies for metformin. It's actively secreted via the organic cation transporter. And as mentioned to you earlier, much of the clearance is based on that. So when we look at this, what this means is that we have very high total clearances of both benzylpenicillin and metformin because of these active secretion pathways, even though the drug is totally cleared by the kidney in that context. And so changes to tubular function may then impact on clearance, and it doesn't relate to the intact nephron hypothesis. Fluconazole is interesting because there is some active reabsorption in the kidney. So to an extent, we need to decrease the dose with decreasing kidney function. But then it gets to the point where we need to stop decreasing the kidney function because a decrease in nephron mass is also associated with a decrease in the amount that's being reabsorbed. And so it's this reabsorption that maintains the blood concentration. So if we're not getting reabsorption, then we need to give more drug relative to GFR. And that's where the dosing of fluconazole can be interesting. There's other examples as well where there are changes in pharmacokinetics with impaired kidney function, and we need to think about how we would make a dose adjustment. This is the example of dihydrocodeine. The blue line shows normal kidney function, and the black line shows someone with advanced chronic kidney disease. So we can see here that there is a higher Cmax and a slightly longer half-life. And this largely relates to the fact that there is inhibition of CYP2D6 and 3A4 activity with uremia, which is what causes these changes. So how would we dose adjust the prescribing of dihydrocodeine in our patients? This is not such a large change in Cmax. The main issue relates to the longer half-life. So we could give the same dose, but we would do it less often. And then we're at less risk of accumulation of dihydrocodeine and the complications, including sedation. But if we compare it to repaglinide, which is used for the management of diabetes, we can see here that there's some marked differences. The blue line again shows a person with normal kidney function, but the black line shows a person with advanced chronic kidney disease. And what we can see here is that there is almost a doubling in the Cmax. And again, we get a slightly longer half-life, whereby it persists. Oral repaglinide is a substrate of CYP3A4 and 2C8, but also one of the organic anion transporting polypeptides. So it's got multiple factors whereby uremia may impact on its kinetics. So how would we dose adjust repaglinide? Well, we could probably give half the dose, and maybe we can give it half as often as well. We'd need more information on that. But we can see here, just on those two examples, that very different changes are required in the dosing regimen for them, if you're prescribing it to a person with chronic kidney disease. So what does all of this mean? That these representations that I've shown you on a number of times really are probably an oversimplification. This formula doesn't apply because if we cut out the kidney function, we know that there may also be a change in hepatic clearance and maybe others as well, such as transporters. And this one also doesn't work completely because those with the flat line, there may actually be a change in clearance as well. But maybe it's close enough in most cases, and it depends on the particular drug. I don't think this is a reason for us to stop teaching our students about these principles, because I think they're important principles, because we're still trying to understand the clinical significance and the generalizability of these changes in uremia. And this is just to show some data from metformin, because in many cases, it seems to be a reasonable estimates. This shows decreasing GFR, decreasing metformin clearance. As I've already told you, you can get some massive clearances with metformin, and it's all through the kidneys, 600 mils, 400 mils per minute. And this is due to the active transporters. And this would make you think that with decreasing kidney function, there is still that proportionality between drug clearance and GFR. And so maybe the intact nephron hypothesis does apply to metformin. So why is all of this important? Well, what I think I've shown you is there are some unpredictable changes in pharmacokinetics in chronic kidney disease, and the extent of this depends on the severity of the CKD and also the drug that we're interested in. While I've shown you a number of examples of drugs which are notable and interesting, in general, data are limited, so broader implications of this is really poorly defined at this point. And it's particularly complicated for us when we're thinking about new drugs because there's such limited data. I think also some of these factors are not commonly considered by clinicians or in dosing guidelines, particularly when they're guidelines which are talking about empiric dosing, whereby we estimate what dose to give to a patient in the absence of pharmacokinetic data. At the moment, it's difficult to know exactly how we can do it any better because we can't always predict which drugs will be affected by non-renal pathways in advanced kidney disease. But what it reminds us that we should be monitoring our patients closely, even if we anticipate that there won't be other non-renal changes to kinetics in advanced kidney disease. So when prescribing to patients with chronic kidney disease, So dose adjustment, I've already mentioned that the purpose is to reduce adverse events, whether it be to sub or supertherapeutic drug concentrations. A common or conservative approach in most cases with kidney disease is to start low and go slow, and I think that's appropriate. Then the rate of dose escalation really depends on what is the clinical target that you're aiming for. If it's blood pressure or HbA1c, then these are often delayed in their response, so we need to change our dosing over weeks or months. This is probably okay in many cases and will avoid adverse drug reactions to supertherapeutic doses. So when does a change in pharmacokinetics prompt dose adjustment? So I've shown you about how you can get changes in clearance. When is it that we'd say that the clearance is important? It's commonly been quoted that if clearance changes by 30%, you should consider a dose adjustment. And that's always been considered conservative. The first time that was described, to my knowledge, was by a PharmD, Dr. Levy, in about 1979. And it was a non-referenced statement. He was considered very smart and quite accomplished, so it's probably true. But the point was that we should consider dose adjustment at that point, not that we need to dose adjust, because dose adjustment largely depends on the drug we're using and its own toxicity. It also depends on the drug, so that relates to the drug, but it also depends on the duration that we're dosing a drug. If we're anticipating that we're going to be dosing a drug for a relatively short duration, then the likelihood that it will accumulate to toxic levels is probably low, and therefore we may not need to overcomplicate decisions around dose adjustment. And a draft FDA document suggested that if there's a substantial effect on pharmacokinetics, then we should consider a change in dose. And they suggested here that an area under the curve increasing by at least 50 or more likely 100% compared to healthy individuals would be an example of when we'd consider dose adjustment. Other considerations, a slow iterative approach that I mentioned before, start low and go slow, doesn't work for all drugs. So for immunosuppressives or anti-infectives, we want the drug effect now. And we need as soon as possible to be able to preserve organs, preserve life, and to prevent toxicity. And we know that many cases whereby antibiotics have been inappropriately dosed to patients with impaired GFR, largely because of uncertainty about the best way to dose. So for some of these drugs, underdosing may be as bad as overdosing. And this is where therapeutic drug monitoring has a very clear role, as I'm sure everyone is aware. So for conclusions about pharmacokinetics and chronic kidney disease, we know that changes are documented for absorption, distribution, metabolism, and excretion. And the extent of this varies between patients, drugs, and severity of chronic kidney disease. More data are required to better define these changes, and careful dose adjustment may be required. And as mentioned also, these relationships only apply at steady state, which is a chronic scenario. What this means here is that, similar to talking about steady state conditions for drugs, much of the discussion that we've already had only applies if you're at steady state conditions for creatinine and the kidney function. And this doesn't occur with acute kidney injury, or it's not the case for acute kidney injury. And so let's now talk about that, because that's another level of complexity. Thank you.